I feel very fortunate of what I'm getting to experience and look at from, a whole litany of resources and just talent of trying to put all that together. And again, in a meaningful way to the end user, which is us as citizens to our healthcare system. It's, hopefully it truly does get better because something has to change.
Without supplies, there's no surgery. Without products, there's no patient care. Welcome to Power Supply, the healthcare supply chain podcast focused on helping you navigate the intricacies of logistics, purchasing, contracting, and supplier relationships. Each episode, we speak with healthcare executives, supply chain leaders, and innovative entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the loading dock to strategic sourcing, from buyers to the C-suite, and across the enterprise, we tackle the real-life issues impacting the healthcare supply chain. Whether you're tuning in for conversation or inspiration, we're glad you're here. You're just in time to hear it from the source and stock up on insight. So sit back and plug into Power Supply.
On this episode of Power Supply, we will speak with Brendan Kelly, Vice President of Business Development at Genesis Automation Healthcare. Hayes, I think you know Brendan, so I think you brought him to the table for us. Did you send him our way?
I sent him your way, and you need to be listening to Brendan. He's got a lot of really good things to say, and you're going to learn about he's a national champion as well. So come on and listen to us today. You'll enjoy it.
National champion Brendan Kelly coming up next after a short break.
Bam!
I'm Hayes Walder.
This is Gary Skinner.
And I'm Justin Poulin.
From the studios of Healthcare HQ, you're listening to Power Supply.
Joining us now on Power Supply is Brendan Kelly at Genesis Automation Healthcare. And, Brendan, we've talked a little bit about how we rebalance power in the supply chain and taking kind of like data transparency and shifting that leverage in vendor relationships, specifically around contract negotiations. So we're going to dive into all of that today. Welcome to the show.
Thank you, Justin. It's so good to be here with you. Appreciate it.
Brendan, why don't you just tell us about your background and like how you find yourself in your current role with Genesis?
Sure. So my background in healthcare started now 17 years ago. I started in device as a 40-year-old in medical device. I joined Zimmer at the time as a sales associate. The job I had previous to that, I was traveling like 200 plus days a year. And I always told my wife, if something got in the way of that, you got to come and let me know and I'll change tomorrow. And that happened in 2007. 2008, I started with Zimmer and then spent 11 and a half years with Zimmer as a regional director in the Mid-Atlantic area where I live. And then actually two guys who founded Kermit, who I went to work for after my time at Zimmer Biomet, John Owens and Jason Smith. We'd always been in touch with each other. I knew what kind of Kermit was up to back in the day. And so finally I said yes to joining them. Did that 7 years ago, which is an amazing transformation. I was the 9th person hired at Kermit, and obviously that grew. And that transition now lately, at the end of last year, at the end of 25, Kermit and 2 other entities were purchased by a private equity firm out of LA called Diversus Capital. They put us together with a company called Genesis out of Cork, Ireland, as well as Maperia, which is a US-based company here. And between the 3 entities, we have been combined into Genesis Automation Healthcare. So I've spent time kind of in the OR as a device rep, at the negotiation table as a medical device regional director, transitioned to the other side of the table, if you will, in my position with Kermit. And now my role is really exciting and I'm going to date myself, as a 59-year-old healthcare person. I am now a vice president of business development, Justin. So I'm putting my sales shoes back on. And I truly am really looking forward to the interactions I get to have to introduce people to Genesis Automation Healthcare. So that's about me.
That's
That's great.
really well done. Yeah, absolutely. Now, and I just learned a few minutes before we started this, you have a pretty cool background story too about your college. Why don't you share that just a little bit with us? I think everybody will find that really
Well,
interesting.
I appreciate that, Hayes, as always. So I'm an alum of Johns Hopkins University. I played lacrosse there at Johns Hopkins in the mid to late 80s. Our team in 1987, I was a sophomore. We won the national championship, which was a phenomenal experience. 2 years later, our senior year, we experienced the agony of defeat in 1989, losing to Syracuse in a great NCAA championship game. But I will tell you, Hayes, that lacrosse for me has changed my life in so many ways. From a networking perspective, it's allowed me to travel to places like Prague, Czechoslovakia, Tokyo, Japan, and in all of the UK. So it's been lacrosse in and of itself from a networking perspective. It's like Baltimore. I equate it to Baltimore. Baltimore is a very tight knit community, and we call it Smaltimore in air quotes because a lot of us don't leave here. As I told you, I've lived here my entire life in the Baltimore area. But lacrosse is similar to that. People spread now across the country. It's one of the fastest growing sports still today. And so, so thank you for mentioning that. I've loved my time at Johns Hopkins University. We call ourselves the 89ers. And quick fact, during COVID, our class had 47 straight Friday happy hours. And it got to be so legendary that we actually had guests come on to our Zoom meetings, and it was so much fun. So we have a great brotherhood and still together. So thanks for mentioning that.
Absolutely. And so, Gary, you need to call him national champion Brendan.
Yes,
I do.
Okay,
Hands down.
That's how he
Humble
should
card.
be addressed.
Yeah. That's
Done.
great.
Done deal. I just want to be invited to the happy hour one of these days. Not as a guest speaker, just as a fly on the wall. Take notes,
Yeah.
write a book. I don't know. Maybe get some knowledge.
Yeah,
So
we need to re up those. We haven't had those in quite some time, but it was a blast. I can tell you, it was really special.
Brendan, I got my start in med sales at the age of 35. So,
Okay.
I have a similar kind of, later pathway into healthcare sales. But,
yeah,
one of the things that was interesting to me is I had a clinical background, but then I got involved in supply chain, and that kind of is like the short way to say this is how we wound up here. And data is like one of those things. I've just seen so much advancement around data since I first jumped in 2010. I mean, just everything in terms of like implementing ERPs and EMRs and just consolidating that and getting it, from spreadsheets to Power BI to now, and a lot of other platforms that are leveraging, AI to do some analytics for us. It really has been a very interesting rapid growth rate of just how we've been able to get data, how we've been able to connect data, and how we started to be able to use data. This whole thing kind of creates a lot more transparency. And so it's changing the game a little bit. And I thought maybe you could, give some context to how this influx, because there's also a lot of systems that are like, we have tons of data and we can't use it.
Yes. Well, number one, from a provider side of things, you all have heard of comparative effectiveness. So comparative effectiveness is written into our current healthcare legislation. And what that is like organizations like the Johns Hopkins School of Public Health, Google, Meta, other organizations like that are in process right now, Justin, doing these meta analyses saying, and I'll just use a total joint replacement as an example, a total knee, whereby they're looking at the actuarial life cost of Justin. And if an implant truly has a long-term benefit to you, better clinical outcomes, and it's worth spending more money up front, that's what they're looking into right now. Where the data, at least from my perspective, comes in, both being on the medical device side and now like on the provider side, helping to manage some of that physician preference item spend. Where I see that coming into play is the level of, and I use this word a lot, the level of fidelity that needs to be associated with that data, because it's not just, I'll use the example of a total knee replacement. It's not just a total knee replacement. It is a total knee. It could be a fixed bearing cemented total knee. It could be a cemented mobile bearing total knee. It could be a hybrid of cementless and cemented. All of those surgical specific data points matters in that comparative effectiveness model. So if the payors, CMS in particular, are looking to pay more for a particular surgical procedure, that's where, again, I see the level of specificity and fidelity for the data to really have an impact, frankly. And organizations who can capture it that specifically will have the ability not only to potentially monetize that data to a CMS, to those organizations from a payer perspective, but it'll give them quality outcome measures that are tied to their reimbursement. So data that you acknowledge, there's so much of it around, especially in healthcare and healthcare supply chain. But if you can get it to a point where it is truly manageable from an accuracy perspective, that's where I think that data question kind of comes into play.
I love the term fidelity. And I'm thinking about a movie that I know you will have seen then, High Fidelity. It's an old John
Yes.
Cusack movie.
Yep.
But I like how you're using that to describe, I think a lot of people would just say data cleanse, right? Data cleansing
Yes.
or clean data.
Sure.
And, I think a big part of it too is like the data sets are just so large.
Mm-hmm.
And, they're not large because some of the data isn't usable or isn't purposeful. It is hard to keep it manageable and sustain that data. So one of the things I'm thinking is strategically, you've got to figure out how to pull out what you want to work with, how you figure out what's meaningful, and then just manage that, right? I mean, would you recommend that that's a good approach to, it can't use all the data all the time?
Absolutely. And, we all know the terminology of low hanging fruit. And you look at item master data as an example. And this, again, like the low hanging fruit of high utilization item master data, that becomes, that's a large piece of data to tackle. And that's where, at least, from our perspective, like an experience, we're applying levels of AI to help normalize it, to help, I don't want to say sterilize it because, I struggle still to this day, and you guys can help me. An item master, why there is no universal item master? That's not socialized medicine. Why is there not like a universal item master that providers can at least tap into and have some outlier specificity to that data? But I go back to that specific piece, Justin, because that typically is the largest data set that hospitals have to manage from. And it has a touch to virtually everything that they do on a daily basis. So we're at least looking at that piece to start applying specific agentic AI models around that.
Yeah. So just to follow up, just for our listeners to understand this too, because it seems like in the past, it was like we would get the data, the low hanging fruit, if you will, the fidelity conversation, clean data in the rears. It always seemed to be like in the rears, like, oh, we get it done. We're working on it. Oh, by the way, when we finally get it cleaned up and we have it where we're at, it's 2 months old. It's 1 month old. Do you see us now moving forward where we're actually getting this data now where it can almost be real time?
Absolutely. And I'm not sure, Gary, what the pathway is for that. What's the conduit to that? But why couldn't we have that?
Yeah.
Why couldn't we? I just, from an obstacle perspective, there are so many layers in the clinical supply life cycle that again, they just create layers, and that impacts not only the accuracy of the data, it impacts the speed in which the data can be cleansed and utilized, all of that. So, it's a great point.
I want to push the button on my computer that hits refresh and it's ready. That's where I want to get to. So I have applicable data downstream that I can utilize. So that's why I'm asking the question, because we got to get there. Why can't we ask for it? Especially with the technology that's coming out and all the AI moving forward, which Justin and Hayes are way smarter on it than I am. And they're probably have better questions than I will do. Hayes, no. I know, Hayes, you're going to bring it up. But I thought I would just dilute it now. But I appreciate that. Yeah. Appreciate that conversation.
Yep, sure.
This is kind of a little off to a tangent, but have y'all ever heard of a guy named Gary Brecka? He calls himself the human biologist, and he worked for some of the larger, at the time, payers.
Okay.
And he talked about their database is by far superior to anybody on the provider side because they've got the information from birth to death and everything in there. And he talked about he's a really fascinating follow, but he would talk about when the patient presents and has knee pain, and then they start to go, well, you needed to go on this medication, you need to do rehab, and he goes, we can pinpoint to the day, literally like 8 years to the day, she will need a hip or a knee. And we also know that once she has that and she has this, she falls, she's going to die in 2.5 years from that day. Like literally, they've got the world's largest database that's never shared with anybody. And actually, he does a lot more in the life insurance stuff, or did. But so you think about that, we really need to get hold of all that data. How valuable would that be for medical device and physicians and everybody else? I hate that we don't have it.
Yeah, I mean, you go ahead. Go ahead, Gary.
I just want to compliment Hayes for going to the patient and mission and outcomes, which it takes him a while to get there, but he went there. And I just want to compliment Hayes. Great follow up, Hayes. So sorry.
No, I was just going to, the only footnote I would add, Hayes, is that I feel very fortunate of what I'm getting to experience and look at from, a whole litany of resources and just talent of trying to put all that together. And again, in a meaningful way to the end user, which is us as citizens to our healthcare system. It's, hopefully it truly does get better because something has to change.
Absolutely.
You were talking about leveraging agentic AI and, it's kind of on the heels of managing the data sets, right?
Yes.
And, one of the things you go to these conferences lately, and I just feel like we're so far past the vision casting presentations, but I still feel like that's what I'm sitting in on is vision casting instead of specific use case. And when you hear agentic AI, you have an opportunity when somebody says that to actually have the realistic use case conversation, because that's what an agent is. It's taking the AI model and it's giving it a specific purpose. And I'd just love for you to sort of like dive into that a little bit deeper and say like, hey, this is how an agent could work so that people start to get a little bit closer to actionable, measurable, because I feel like it's still people like they're dreaming.
Yes.
And there's a lot of people who have access to limited tools. And so they're like, not really sure.
Exactly. So here's what we hear, and I'm sure you all hear it too. Brendan, I don't have time to hunt. You guys are giving us really unbelievable rich data sets. And you say, Brendan, you say to us, it's actionable insights. Well, I have to go hunt and peck for what those actionable insights are. We give a high level overview of what that could be, Justin. So what we're doing is layering the artificial intelligence and applying that AI agent. And I'll just use an example, again, a total knee replacement, and saying to the end user in the supply chain, pull up this agentic AI model, and you're instantly going to have surgery specific data points across a vendor cohort, across a surgeon cohort, and where there are immediate outliers in real time. So if you want a month's worth of data, and it will point you in the direction of, hey, if there was, I don't know, a standardization opportunity across a certain surgeon cohort, you would have X number of dollars potentially in cost reduction activity. So the model itself is going to be working behind the scenes. For us, it'll be in specific surgical divisions that it will help whoever the end user, the hospital system user, an individual hospital user. It'll allow them to instantly go to the model and just point out specific areas of opportunity. Now, everybody listening might say, well, Brendan, we do that already in real time. The difference, I believe the difference is we're pulling from surgery specific apples to apples comparisons because I've lived it. I've gone into spine surgeon cohort meetings. I've gone into CRM surgeon cohort meetings, total joint, anything orthopedics. The surgeons want apples to apples specific data.
Yep.
And when you're comparing, you're not just comparing my ACDF, to another. I'm doing a certain approach. I'm doing a certain number of levels. All of that comes into play, Justin, for those specific opportunities. So that's how we're at least creating the modeling that a lot of you guys will go to ARM. You'll see that there.
How do you see that go into use? Like, so here's another example, right? I mean, is this like down to the contract managers? Like, I know the big opportunities are going to be sort of like you're going to be hinting and pucking with the AI model, at that sort of strategic sourcing level or the VP level, and they're looking at those big projects. But I'm also thinking about just that contract manager staff where it's like, how do they figure out what the next right opportunity is? You're curating that decision making with the agent is essentially what's happening. Is what used to take them 4 or 5 days of data mining only to come up with this is probably not a lot of opportunity here, on to the next. You're doing that faster and more proactively so that when they're coming off a project, bandwidth opens up, that they're ready and have identified the next one. Is that kind of how you see that in practice?
You're spot on. And one great use case, Justin, think of the ambulatory surgery centers or even the surgeries, like specialty surgeon hospitals, surgical hospitals. The people in those organizations, I've seen it firsthand, they wear a ton of different hats. Their responsibilities run the gamut, from processing purchase orders to being a circulating nurse in the OR. So those facilities, the model will absolutely benefit in a significant way because they'll turn on their computer. The model will say hello to them and say, this is what you need to pay attention to today, Justin, or this month. And again, we're trying to be very cognizant of information overload. So that too becomes a perspective in the model. Okay. So the use cases run the gamut from large IDNs down to ambulatory surgery centers, but you're spot on in terms of I have to be able to efficiently engage and act upon that opportunity. And there are governance playbooks that the AI, the model will write for the specific use case. So it's basically a playbook on how to actually deliver the results, and other organizations can participate in that. So,
All right. I want to transition the conversation a little bit to, we get that data can empower the health system, but how does that change the dynamic, like kind of the purpose of this in negotiations, with the vendors and suppliers?
Yeah. So the data piece to me, and again, there's an emphasis on physician preference item spend, and a lot of the medical devices, good, bad, or indifferent, are approved through a 510K process. I think you all know that process. The core of that process is substantial equivalency. All we have to do as a manufacturer is provide sufficient data to prove substantial equivalency to a predicate device. So the device, if you look at it from a family tree perspective, you would go back in time, and statistically, the data says the technology 20, 30 years ago, from a long-term clinical perspective, is the exact same as today, 7-year out technology, which we are paying more for because that's just the lay of the land. That's how it happens. So Justin, to your question, the data around that piece from a negotiation side of things, that can be brought to the forefront. Why would any provider pay more for substantial equivalency? What is that all about? I still to this day, I didn't really realize how critical a piece of information that is to the healthcare ecosystem. Okay. So that from a data piece right there is a significant contributor to have the provider, say to any vendor, show us the long-term data. Like, cause there is a pathway to doing that. Pharmaceuticals have to do that. There's pre-market approval process. Takes a lot of money, a lot of time. These are double-blinded, placebo-controlled studies, this, that, and the other. And again, they just take a lot of time. Whereby the 510K process allows me to bring new technology to market, but just at that equivalency level. So what truly is the benefit is remains to be seen.
Brendan, can you just kind of give us, without naming names, obviously, but where are we in pricing these days on, let's say, hips and knees? Where on that curve are we? Is it still going up or fairly flat?
Yes, we are close to the dip, Hayes, right? We're close to the dip from a U.S. perspective. I still kind of follow and monitor gross profit margins for a lot of the big med device, and they're still very healthy. So they can still compete on price. But from a global perspective, and look, we all have access to information. When, again, not that we're not going to name names, but equivalent implants here in the States versus other parts of the world is significantly, we still have a long way to go to get to the dip, but we are well on our way to that. And it's hard, Hayes, because the technology that medical device companies bring to market it's phenomenal. It's again, like on the hip and knee side, it's arguably the most successful surgical procedures ever invented based on long-term clinical outcomes. So the technology and that piece is really valuable. And I'm still a firm believer. I still talk to a lot of medical device friends. There's a significant amount of value that the vendor rep adds in the OR. The safe and effective use of products is significant. It truly is. From somebody who's been in that environment for 11 and a half years, the vendor reps, 95, there's certainly outliers, but 90+% are just so dialed into making sure that case goes perfectly. I can't say enough good things about that. But as far as a price perspective, and we live in a free market capitalist society, we have access to that information. Hey, so why would we pay more again? Like this is the dynamic that we're in.
And if I were to look at, say, 6-7 years ago, product that was the best compared to today, is there incremental improvement in the product, or is it really different?
Yeah. It at this point in time, and again, I'd love that the medical device community can kind of chime in here.
Yeah, but they will.
I'll use a vitamin A / antioxidant polyethylene. Okay, and my time at in medical device, that technology was coming to fruition. Okay, better oxidation, better wear characteristics, better strength,
argon gas, the whole nine. Yeah.
Brendan, my litmus test was always, would I allow this implant to go into my body? Vitamin E, hands down, yes, it would. But to date, so that technology, Hayes, has been around for several years. To date, I haven't seen any peer-reviewed statistical data that says it's better than highly cross-linked polyethylene. That's just one little example in that piece of the conversation. So where are we? Yep, it remains to be seen. There's a lot of activity, Hayes and team, around antimicrobial coatings to implants to prevent infection. And infection is horrible in any surgical procedure. So whatever we can do to fend that off, the better. But there's a lot of work on that right now.
I'm a recovering joint rep from many years ago. Yeah. So yeah.
Yep. It's great.
One thing I want to talk about is, kind of like moving the relationship along, because a lot of times hospitals are relying on vendor data to make decisions. And the vendor data isn't always the best data either, right? Like they're going to cleanse it to the purposes that sort of matter to them. And I don't mean that in a negative way. I just mean if you're running a business, data means something different to you than somebody who might use that data. But a lot of times hospitals are like, tell us what we spent.
Mm-hmm.
And, then we get tied into like, contract compliance and pricing variations and all of that stuff. And so, partly if you think about the transparency, I almost wonder if it's seen as threatening. But then there's another element of it is that maybe there's a way to bring the data together and you're actually having more of a pointed conversation so you can yield better results. So like, I just feel like there's a lot of slices at that apple and it really kind of depends on sometimes just your experience from, one company to another, how you might view that and what portfolio you're managing. But I'd love to get your insight on, is there a way that even though it sort of makes both parties feel a little exposed, that they can actually do something really productive with it?
Yeah, that's a very interesting question, Justin. The lens that I use today, when I look at the data that the company I work for today produces versus what a vendor and or provider can truly give as usable information, there is a difference. There truly is a difference. And to your exact point, I don't know, why one would pit one versus the other than their, interests selfishly. But from a comparison end of things, and maybe rebates are a great example in this, that why would the vendor go ahead and, give down to the nth degree data to the provider that they're about to pay a rebate to? And on the provider side, you're exactly right. A lot of them, they always struggle with capturing rebates, whether it's a unit volume growth, a growth percentage, a market share percentage. All of those data pieces matter, in the example of a rebate. But the data sets are, you're right. It's unique paradigm in that they're completely opposite in terms of what could be reported in any given month, quarter, or whatever. So I don't know if that answers your question. It's an interesting topic.
Brendan, you bring up some really good points and the AI piece. And I think we touched on it earlier, but if you were to give like your crystal ball in the next year or the next 2 years of what you think is going to happen, and we've talked about a lot of things, EHR to EMR to ERP to inventory to exact specific line details in the medical device, your total knee analogy.
Mm-hmm.
And that partnership with the vendors, how are we going to pull it all together? How are we going to pull it all together? And what are you seeing down the road that's going to create efficiencies, efficacies that support the patient and the mission of what we're trying to do in healthcare? Appreciate your input on this.
Yep. So Gary, at least what I've been exposed to is something similar to what happened at Intel, where they wanted to innovate every 18 months. They wanted a new chip. With what we're experiencing and looking at, and how quickly, as an example, an agentic AI model can be built today, I feel like we're going to see leapfrogs in not only patient care, with what AI can do from a diagnostic end of things, but on the supply chain side, honestly, it kind of remains to be seen. I mean, you and I, we get exposed to this type of stuff now every day within our organization. And so like the crystal ball for me is what's going to happen in 6 months from now, not 18 months from now, with respect to how this technology is going to hopefully positively impact the supply chain side of this.
Well, I just think about it. I think about all these newbies coming out of college,
Mm-hmm.
graduate degrees now in supply chain. What are they studying? What are they learning?
Mm-hmm.
I mean, the old school mentality that, Justin and Hayes and yourself, that we all
Mm-hmm.
talk about, how we used to evolve it in the triangle, spend to the contract, to the negotiation, to the clinical use, to the patient, it is changing. It's becoming less of a triangle, more like a polyhedron. I don't even know the right word, Hayes. You're going to have to fix that for me. But it's becoming so big. I don't want it to be so big and become so cumbersome, but we can actually apply it to that specific case mentality. I think that's the most important thing that we can really dive into is utilizing, Justin talked about just seeing the vision and just,
Mm-hmm.
pie in the sky and the dream. It's like, it's time to implement what makes sense and quit changing the name and quit coming up with a new model. And it's changing every month. What do you tap into? What do you grab to make it more effective to our listeners, to make them more effective in their rural hospitals, their ASCs, their giant IDNs? What are they going to grab onto to move forward? And that's why I bring up the topic, because we got to grab something that makes sense to support our outcomes.
Yeah. Agree.
Yep.
And I feel like, the cost side of things is always a first look. It just is. You can't labor cut your way out of financial destruction. You just can't do that. So
you have to balance the fiduciary responsibility with the clinical need all day long. And that's an easier term than said, but it is. We have to balance it. You have to answer to the CFO and you got to answer to the surgeons, and you've got to make sure we keep the doors open. Single days cash on hand are not successful to an institution to take care of our patients, to keep them at home versus sending them, across the country to go get care. That's the thing we got to take care of.
Yep. Supply
David
chain.
says that's okay because you're sending them to Hopkins.
There you go.
I love it. All good.
But any final thoughts before we wrap up? I mean, this is great conversation today.
No, thank you all just for the opportunity to have the conversation. I've listened to several podcasts knowing that we were going to come on, and so it's just been a lot of fun. Appreciate I guess the informality to the formal nature of what you guys do. It's really cool. So thank you for exposing me to that.
Yeah, we have a lot of fun with it, Brendan. Thanks for coming on.
Yep, appreciate it.
That was Brendan Kelly, Vice President of Business Development at Genesis Automation Healthcare. And we're really talking about leveraging data for transparent conversations with vendors. And with all the tools that we have available to us today, we can really reshape those conversations. And I love what he said about leveraging agentic AI and actually getting a use case, in a category for a contract manager. How do we identify in a quick manner areas that are going to bring in the most opportunity and the most impact based on what we're seeing? And like a lot of times there's shifts in the market and it's hard to keep up with those. And so this is one of those ways where, you want to make sure that you hit that window before it closes.
No, Justin, I think it was a great conversation with Brendan being on board on this. I mean, I think you, Justin, and him hit it off when he talked about specific use cases, like not be pie in the sky, not dreams, but how do we truly implement it at the boots at the table, at the ground, balancing the fiduciary responsibility, supporting the mission. And I thought you guys really jumped into that, but just a wealth of knowledge from Brendan and really figuring out that partnership with the vendors to really support it. I think we're going to evolve so quickly, leapfrog. It's like not a year now, not 6 months now. It's like every other month this is evolving, and how do we apply it? So great information. Great host today. Great host, Justin. That's you. Great to have Brendan on board. So Hayes would laugh at that one. He was great. So Brendan, wealth of knowledge. So great podcast.
Another great guest in Brendan on the show today as we're getting close to the end of the season. You two are great hosts, Gary and Hayes. And on behalf of both of you and myself, I want to thank everybody who's listening to the podcast today for joining us.
Bam!
Thank you for listening to this week's episode of Power Supply. As a reminder, you can help support us by subscribing on your favorite podcast app or by downloading the smartphone app on your iPhone or Android. Simply search for Power Supply in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@powersupplymedia.net. We look forward to hearing from you.